My name is Sam Church. I'm a consultant knee surgeon at Fortius. I specialise in all aspects of knee surgery, including arthroplasty and revision arthroplasty, soft tissue knee surgery, ligament reconstruction, revision ligament reconstruction and multi-ligament reconstruction. One of my specialist interests is anterior knee pain in the athlete and overuse syndromes of the knee. I'm going to start quite dramatically by saying I do believe there is an epidemic out there, which is an epidemic of anterior knee pain amongst urban athletes who use running or cycling to maintain their fitness in their concrete jungle. And it really is common. It affects 1 in 5 active females, 1 in 8 active males. It affects 40% of military recruits during basic training. It's got an incidence of 2.5 million runners per annum in the USA. That's the number of new cases per year in the USA, and it is therefore undoubtedly the commonest cause of all knee pain. And yet, 5 years after completion of a rehab program, 80% of patients have persistent pain and 74% have a reduced activity level. So why is that? Well, the reason is that the medical community, and I mean medical, not physio community, the medical community does not want to admit that this condition exists. It doesn't know what causes it, it doesn't know how to treat it, and it hasn't even got a name for it. So why don't we start by trying to give it a name? Now, it's not patellofemoral pain syndrome because it doesn't originate from the patellofemoral joint. It's not quite ITB syndrome. ITB syndrome is a subset of this condition, but it is not the whole thing by any means. It's not runner's knee. Runner's knee usually refers to ITB syndrome, but I don't like that term because actually you can get it, or athletes across the whole spectrum can get this condition. It's not idiopathic anterior knee pain because it's not idiopathic, and it's certainly not chondromalacia patellae. So, as the title of my lecture may have suggested, what I like to use is the term lateral patellar overload syndrome. I think it's the most descriptive term, the most accurate term, and it's not open to so much misinterpretation as some of the other terms. So now that we've got a name for it, what causes it? Well, you guys know all this. We don't, but you do. It's poor biomechanics. The underlying problem is one of a weak gluteus medius. If you chuck in a bit of forefoot pronation with that, you get internal rotation of the hip during the stance phase of running. And then, when you have to initiate knee extension during the swing phase, it's done by TFL, by tensor fasciae lateralis and vastus lateralis, which are pointing forward rather than by VMO. And you get a vicious cycle of ITB dominance and glute weakness. And when you have this, repetitive knee flexion and extension leads to ITB bursitis or friction syndrome, which is well known but actually less common, or its very common and less well-known cousin, which is superior lateral fat pad impingement. So how do we make the diagnosis? Well, as always, we start with a history. The history is classically lateral or anterolateral pain during or after running. ITB syndrome often comes on very quickly after a very predictable distance. So sort of 8K into a run, bang, it comes on rapidly in a matter of strides, and it can bring you to a halt. Fat pad impingement is slightly different. It will usually come on by the time you reach the end of your street, but it's milder, it grows much more slowly, and people are often able to complete their run, but they're punished afterwards for 24 hours or so. The symptoms will classically start with a change of exercise pattern. You're training for a big race, a change of footwear, a return from injury. That's the really classic one, when someone's been off with an ankle sprain for 2 or 3 months and they go straight back into their standard running pattern. The symptoms will then become more frequent, and they'll progress onto the stage where the patients will even start to feel it during normal activities of daily living, such as walking downstairs, if they continue to run. Examination, I get the patient to stand up. I look at their coronal alignment. Are they varus? Are they valgus? I get them to do a single leg squat. This is something that you guys have always done, but no doctor includes as part of their standard examination. And you can see the pelvis drop. You can see the knee drop into valgus. I look at their feet, obviously, and then I look for tenderness. Are they tender in the fat pad? Are they tender over the ITB bursa? Fat pad tenderness in particular is quite hard to find, but if you dig your thumb in there and then you get them to extend the knee and keep your thumb there, you can find it very easily, and they'll say, that is the area of pain that I get. And you'll often find crepitus with it. That crepitus is not irregularity of the articular surface on the back of the patella, as most people think it is. It's fibrosis in the fat pad that causes the crepitus as a result of chronic inflammation. I'll look at their patella tracking. If that is bad, if that's way off, they've got a big J sign, if they've got lots of lateral glide, lots of patella tilt, it may be that you need to consider a tibial tubercle transfer in some of these patients, but that's rare. look at how tight their hamstrings are, which you guys know all about. Then I'll do a modified Ober's test, and we've modified Ober's tests in my clinic so many times now that I can't really remember what the original one was, but it's something similar to what this girl's doing here, except that I would have the contralateral leg flexed up much more to fix the pelvis much more, and I would have my hip against the patient's sacrum to stop them tilting backwards as you bring the hip up and out into abduction and extension. Then I'd come down into adduction, and we gauge how tight the ITB is by where it sort of flops to, and anything horizontal or above is tight. And then the way we've further modified it is once you've tightened it, once you've got it to its point of maximum stretch, if you then flex and extend in that position, you can perfectly recreate their symptoms. Even in the patient who said, oh, I haven't had symptoms for weeks, you can bring that back on. And then modified Thomas's test is also great visually, and we'll come back to that in a tick. Investigations. There's only one investigation really that's helpful here, and that is an MRI scan. But crucially, you've got to do it when the patient is symptomatic. So they've got to be symptomatic. Get them to run up and down the stairs before they walk into the scanner. If you do that, you'll convert this, which is some nice sort of mild inflammation. This same patient, after running up and down the stairs, looked like that. And then this lady just happened to be a professional marathon runner, and she let me scan her knee the day after doing the Loch Ness Marathon. Fat pad impingement is more predictable on an MRI scan. You can usually pick it up if it's there. This is it on the axial view. You can see it's that area there. You can see it on the sagittal view there. And you can see it if you get a good coronal slice straight through the fat pad in the right place. You can see it beautifully here, where this side of the fat pad, the lateral side, is inflamed and the medial side is not. And the reason I showed these films is that these are the patient I saw a couple of months ago for a second opinion who'd had this MRI done elsewhere, and it was reported as normal. But more often than not, as I said earlier, the patients have a combination of both. It's very rare to get one in complete isolation. So here's a typical patient where you've got fat pad impingement here on the sagittal view. You've got ITB syndrome on the coronal view, and then the axial view shows it quite nicely on both. So how do we treat these patients? Well, as surgeons, if someone comes in with knee pain, we target the knee, and you know, a lot of physios do the same thing. They do knee-orientated physiotherapy, ITB stretches, VMO strengthening. And then cortisone is a really interesting one, because cortisone is never going to change the underlying biomechanical problem, but it can be useful. I accept the fact it can be useful. It can persuade a patient who's had umpteen courses of physiotherapy to maybe give it one more go if you can get rid of their symptoms for a short time. It can be useful in the person now who gets ITB syndrome and is desperate to run the marathon but intends never to run ever again. It might get them through that. But it does not change the underlying biomechanical problem, and it does not treat them. The correct treatment, however, is to target the hip, because that's where the problem is. If you can strengthen gluteus medius, if you can keep the pelvis nice and steady while the patient's running, then you can present the VMO facing forward as they're running, and they won't get this problem. But what happens when physio doesn't work? As surgeons, we have three main tools. We've got you guys, physiotherapy, we've got injection therapy, and then we've got surgery. And so if they've had a cortisone injection and they've had physio, we all tend to think of surgery. But the alternative, this is where my Botox bit comes in. If we can switch off the ITB completely, if we can switch off TFL to give gluteus medius a chance to function, a chance to get back up and to compete with it, then maybe we can solve the problem. So I inject a particular variety of Botox called Dysport into the belly of tensor fascia lata under ultrasound guidance. This works for 12 weeks essentially. So it gives a 12-week window of TFL paralysis during which the physiotherapist can work on recruiting and strengthening their gluteus medius and secondarily their VMO. So when we first started doing this 5 or 6 years ago, we set up a pilot study looking at 25 patients just to make sure that this was a viable thing to do. And to cut a long story short, we measured ITB length using a fluid goniometer. It was a validated method, and we confirmed that by paralysing the TFL, the ITB was lengthening, and we were therefore defunctioning it. And we also confirmed that the patient's Kajala score, which is a patellofemoral function score, increased significantly. But what was really interesting is what happened next, i.e. once the Botox wore off. And 19 of the 25 knees remained satisfied and required no further treatment, i.e. glute med got strong again, it could compete with TFL, and their biomechanics were once again in line. 6 of them, the ITB came back to dominant again. They have a further injection, of which 3 were subsequently satisfied. And then the remaining 3 I gave up and I lengthened their ITB, 2 of which improved. So we had a 96% satisfaction, and all of these patients had failed conventional treatment. In other words, this was 96% where conventional was 0%. How do I do my ITB lengthening? So when the Botox does work, but it keeps on recurring, I need to lengthen the ITB permanently. I do it through a small incision on the lateral aspect of the knee. And after this, I'm just going to show you a series of simple diagrams to try and explain what I do. This is obviously the lateral femoral condyle here. This is the lateral epicondyle, and this represents the ITB band coming over the top. And most people, a traditional operation, one which I did a lot in Australia, there's an awful lot of ITB syndrome in Australia, is an ITB release, which is just where you cut down through the posterior 2/3 of the fibres at the level of the lateral epicondyle. And so it springs apart, it releases the bursa. The bursa is no longer under pressure, and so the patient's symptoms should resolve. But the problem is these fibres here, anterior third, are all still intact, so the ITB remains the same length. What I do is I've added in another incision more proximal to that through the anterior 2/3, so actually every single fibre in the ITB is being divided, and that way it can actually properly lengthen it. It's a well-known plastic surgery technique called a Z lengthening. So you get this effect and you get that, and that adds genuine length. It effectively defunctions the ITB, which then means that the patient uses their glute med. So my current algorithm for these patients is to MRI them, determine whether they're fat pad, ITB or both. They always have a course of good physio, and you ask them, if they've seen lots of different physios, you ask them, what have you been doing? And I do generally inject every single one of them with cortisone because I have to, because I'm not allowed to use Botox off license, which is how I'm using it, unless I have exhausted conventional treatment, and conventional treatment includes cortisone. I'll then do Botox, which I will repeat up to 3 times, and the patients will often get better and better and better after each one, but if they're still symptomatic after 3, I'll go on and do the ITB lengthening. So we've now injected over 200 patients, 38 of them have gone on to have an ITB lengthening, so about 20%. And we're formally writing up our data with Imperial College at the moment. So I can't give you exact facts and figures, but our research analysts have said that basically about 80% of patients feel that they have been successfully treated. Now that still means 1 in 5 is not, but that's an awful lot better than the 4 out of 5 using conventional treatment. So in summary, lateral patellar overload syndrome is a very common cause of anterior knee pain in runners. The underlying cause is a biomechanical imbalance at the hip. You guys should primarily address recruitment and strengthening of gluteus medius. Cortisone injections can be useful, but are short-lived. And if physio fails, defunctioning the ITB with an ultrasound-guided injection of Botox into TFL or surgical lengthening of the ITB results in significantly better long-term relief than conventional alternatives. Thank you very much.